Good afternoon, everyone. Thanks for joining me. I do apologise to be a little bit late and as organised as always. Going to go talk a little bit about echo in patients with ARDS, heart-lung interactions, and I'd like to take through a case that we've been battling with a little bit within the unit, which I think demonstrates some of this really beautifully, and there are some great learning points, I think, in this. I've got a gentleman who's 74 years old, who's got a background of having shortness of breath under investigation for the last 6 months. And he's had a CT chest that was done about a year or so ago that was suggestive of some fibrotic lung disease and called interstitial lung disease. And the exact etiology of that was uncertain. In the last 10 days, he's come in increasingly short of breath and hypoxic on the wards. And this was his chest x-ray when he came into hospital about 2 weeks ago, showing what was thought to be a fibrotic lung process, with on CT scan showing some interstitial fibrosis-like pictures, some contractures in some of particularly the right upper areas. And this has progressively worsened with worsening hypoxia. So what we're going to, first of all, just show you this chest x-ray, sort of help might paint a picture for this gentleman who doesn't have a lot of comorbidities other than this lung disease, not previously on home oxygen, with a fibrotic lung picture with potentially another process such as an infection on top of it. Okay, so has everyone got that so far? All right, so let's just start off with let's just start off first of all with his echo. So he had an echo done on the 5th of August, so that's a good 2 weeks ago. And this is where I want us to start. So I'm taking us back when that chest x-ray was done. This was this gentleman's echo. And he has no major findings on his biochemistry. He's got normal renal function, normal LFTs, and the echo I'd like us to go through a little bit. So again, this is 2 weeks ago. I hope that's coming through okay. Where should we start? Emma Bocock, I got you at the top. I think everyone's in alphabetical order, so unfortunately, Emma, I believe you're first. Emma, do you want to start us off?
Sure, I'll try. So parasternal lung axis, the left ventricular size appears normal. The walls, without measuring them, appear like they are hypertrophied, both the posterior wall and the anteroseptum with a sigmoid-shaped septum. The systolic function looks okay. I'd like to interrogate his diastology. The left atrial size, in saying that, doesn't look too enlarged. The mitral valve, as far as we can see in 2D, looks normal, as does the aortic valve. Perhaps the aortic root looks a little dilated, or the aortic sinuses, but we need to measure that. And the RV in this view, I think it's slightly down, like, you know, if we went up a rib space, perhaps it'd be different, but the RV looks generous in this single view.
Really nice. I like the idea of generous and don't make any wild conclusions based on the parasternal lung axis view. And you said that very nicely, so beautiful.
One thing.
Yeah.
Do you think it's a pseudohypertrophy?
Interesting. So the question was, I don't know if you can hear that Vishal's here. He asked, do I think this is pseudohypertrophy? Do you mind explaining to the group what you mean by pseudohypertrophy?
So I think, like two things, I thought in this view. The first thing, I thought the patient is hypervolemic in this particular view. And the second thing, I think, the parasternal lung axis is a bit foreshortened, because I almost can see the apex almost. So that's for the two reasons I thought.
Interesting. And one other thing that might contribute to that is we can also see the papillary muscle, which might suggest that we're off axis as well. So yeah, nice thought that so if we think he's off axis, I think it's a little hard to say that he's hypovolemic. I think we can't say anything about his volume status if we think we're off axis. So all of those, everything else I agree with.
I think there's Samus Daniel here. There's just a couple of other things that I think you could pretty much say for sure, is that his pulmonary infiltrate is not related to aortic stenosis and is not related to mitral stenosis.
Really nice. So bring it straight back to the clinical side of things straight away. Very nice. Emma, I'm going to keep on hammering you for a little bit. So these are just little signs of features, rather than take us through the whole image. But there are a few things that I'd like to jump out of you when you're starting to report these things. And I'll show you what jumped out of me when I was going through these. So what's jumping out of me on this one? Emma, you still there?
Well, the RV looks trabeculated.
Right.
It's the RV inflow view. Probably
and so some people are going to just be starting doing the echo. So the RV inflow view is when you're on your parasternal long axis view. You just tilt the whole probe down so you're pointing it towards the right hip. And here we've got the right ventricle, and there's the tricuspid valve, and the right atrium should be in there as well. So tell me what you mean by the trabeculations. That's exactly right. So we've got apical heavy trabeculation in the RV. And what does that mean?
Well, it suggests that there's a chronic exposure to, you know, a pressure overload. So I'd be,
brilliant,
you know, thinking, has he got long-standing pulmonary hypertension?
And what would be the next thing that we could look at after the trabeculation?
Well, I'd want to look for tricuspid regurgitation.
Yep.
Or the thickness of the wall. Look for hypertrophy.
And what's abnormal?
More than 6 millimeters, is it?
Yeah, 5. Yep.
5.
Okay. All right. So let's go and have a look at pulmonary hypertension. So let's first talk about systolic pulmonary artery pressures. Ben, how are we going to assess systolic pulmonary artery pressure in this patient?
So, assuming we're not doing things invasively, assuming we're doing things non-invasively.
Yep.
Yeah, he's in ICU. Remember,
we're doing
a
tutorial. Yeah, definitely. How do you do it with echo?
Yeah. So what I want to do is I want to get a apical 4-chamber shooting through his tricuspid valve and seeing what the TR jet looks like, and then get the maximum velocity from that, and generate what pressure is from there, and add his right atrial pressure. Is that what you mean in terms of?
Very good. And just to pick you up, so absolutely right. So apical 4-chamber, we can look at our tricuspid regurg jet, and we can look at the Vmax of the tricuspid regurg jet, and we add on our right atrial pressure estimate, and we can talk about doing that based off the IVC and the hepatic vein, and we'll maybe talk about that a bit later. The caveat and the reason I was asking you is just the importance is to know is that is just one of several views that we can look at to estimate it. And the first one's going to be this. So I take the highest Vmax I can find anywhere in the heart for looking for my systolic pulmonary artery pressure. So the first place we're going to look would be this view here, the RV inflow view, tilting down from the parasternal long axis. The next one we're going to have a look is going to be the short axis view at the level of the aortic valve, where we can tilt over and look at the tricuspid valve there. Then we've got our apical 4-chamber view, and even sometimes in the subcostal region, we can get both if we've got a slightly eccentric looking TR jet, you can sometimes get the TR jet in that 4-chamber subcostal, or you can go into your short axis in your subcostal view and do that. So you've sort of got 5 different views to go and try and find the maximum velocity. So the standard answer is, you know, as you said, the TR Vmax plus the right atrial pressure is our systolic pulmonary artery pressure estimate. And we will look in all views possible to try and find the maximum velocity. Beautiful. So this is what we've got for our first one. Let's have a look at that one.
Right. So maximum velocity, 3.23 meters per second. Just off the numbers, looking at the quality of the trace.
Very nice.
You know, it looks, we've captured multiple cardiac cycles, 4.5 there. And where the marker seems like an appropriate point. Looks to be the biggest as well for what it's worth.
Yeah, I might just say that I think that previous one where it was up there, that looks overgained to me. So we've got to be careful when we're making these measurements, we ignore the fuzz.
Yep.
We'll turn down our gain until we're looking at the modal velocity. So that's where the majority of blood is flowing and we're capturing it. So I think we'd turn down the gain to here. And I think probably the measurement would be more in keeping with something like maybe a 2.7, 2.8 or so. So we'd take the maximum velocity, so maybe be that one. So it might be a little bit less than we've done. It's probably, you know, not making a massive difference to what we're going to conclude, but just to make sure that we're measuring it accurately. And that includes on the Doppler trace, just like you said, having the baseline at the top of the image, what we're interested in filling the screen, 4 cardiac cycles across the screen, not 14 or something, and then just turning down the gain, looking for the modal velocity. Beautiful.
Yep.
But those are also not completely full envelopes, are they? So whatever you've measured there, it's going to be probably something slightly above that, but you just don't know where it is.
Yeah, completely. And that's why it's important to look at it in all different angles that we possibly can. So, for example, we had, they measured 3.23 up there, and you can see how many different jets that we've got. So that's a tricuspid regurg jet in the RV inflow view from your parasternal long. Down here, if you can see it at the bottom, these are from the short axis view at the level of the aortic valve. As we flick over, we're going to start to see they're going to be looked at after the diastology. We look at it in the apical 4-chamber view. Here we go in the apical 4-chamber view, the TR. So, multiple measures of the same thing over and over and over again. And that's how we make sure we've got an accurate trace. Beautiful. Danielle, what else have we got to look for pulmonary pressures? So that's how we get our systolic pulmonary pressure. Tell me what else you want to see.
So I'd be interested to see the RV outflow view and to look at a CW or a PW of the pulmonary valve. Yeah.
Cool. I'll give you the PW first. So the pulsed wave Doppler.
Yeah.
So this is sitting in the, so after we've done our RV inflow view, tilting down, looking at your right hip, you then tilt it up the other way, past the standard apical parasternal long axis view, and this is where we get our view here. So this would be the pulmonary valve coming down here. Pulmonary valve is just there, so we're sitting in the RVOT with pulse wave Doppler. Beautiful. And what are we looking for?
So this is looking at the pulmonary valve acceleration time, which I would usually measure using as broad a time scale as I can, because you're measuring very small time intervals. Normal would be greater than 130. And I guess, a suggestion of elevated pulmonary vascular resistance would be perhaps, around the 90 or less mark. So if you were going to take the measurements that had been initially done, which were around 100, it's kind of in the borderline. Yep, so there you've got, 95. So, slightly low, but it doesn't really clinch it for me one way or the other, to be absolutely certain. Also for really elevated pulmonary vascular resistance, you might be looking at the notch deceleration of the waveform, so the flying W sign, which I didn't see on those ones that we just looked at there.
Yeah, really nice. And so
it's not normal, it's low, it's consistent with elevated pulmonary pressures, but I think it's a bit non-specific.
Because we had, based on what we saw last time with the tricuspid Vmax, if we measure, say it was around about 3, that would give us peak pressures of 3 squared times 4, the modified Bernoulli equation. So that's 3 squared is 9, 9 times 4, added on right atrial pressure, which, let's say we got an IVC that's going to be dilated. So we'll give it sort of 8 to 10. So we're looking at about systolic pulmonary pressures of, say, around 45, 50-ish maybe.
So that's kind of in the moderate ballpark. You also can use formulas to estimate the mean pulmonary artery pressure from the pulmonary valve acceleration time, but I have to admit I have not committed them to memory.
Yeah, and there's a reason for that, is because they're rubbish. There's an enormously complex equation that doesn't work very well when you've got tachycardia, or certainly hasn't been validated in the critically ill, and I'm pretty sure it's been validated on about 20 patients in the non-critically ill.
So yes, I don't use them, no.
I don't mean to bag out the people who did that great research, but it's I don't know. It's not. I agree. I don't use it a lot. So just to pick up on a couple of things that you said. So you're absolutely right that this pulmonary acceleration time, they say, is abnormal is less than 120. So that's suggesting a short acceleration time, which it'd be in keeping with increased pulmonary vascular resistance. The acceleration time has been best related in the evidence to pulmonary vascular resistance. The notching that you describe is related just to, I think it's related just to pulmonary hypertension. So to mean or peak systolic pulmonary artery pressures. I think they're obviously related, resistance versus actual pressure. But just to, I don't know. I'm pretty sure that's not a pass or fail thing, but just...
No, that's good, because I think in my head it was actually the other way around. So thank you for that.
This is the resistance, and I can show you the paper where I get that from in a sec, if you like, if I remember. So I use 90 as the cutoff. So here, if we're sitting at 95, exactly as you said, if I move this little probe back just a tiny bit, I'd probably get a marker which would go, give me 110 milliseconds versus 90. It's a very small movements make a fairly big difference. So yeah, using the value of 90 though is the one that's been most commonly linked with raised pulmonary vascular resistance. And anything else to make sure that you're accurate? I also like to see this closing click sometimes. I think.
Yeah, and I'm sure I've read something, might have been Bonita Anderson or another book, where they recommend actually starting from the peak velocity and measuring backwards. I'm not sure exactly how that makes a difference, but I think it's just related to starting with the highest velocity and then bringing it back to kind of, the start of the waveform somehow. I don't know if that just makes a difference to the way your eye reads it.
Interesting. I think also maybe trying to optimize it a little bit, getting that gain down, picking, I think his first trace here would probably be the best to do, and, increasing up the horizontal sweep and trying to find that trace again, those might all be little things that you can do to try and make sure you've got an accurate, to get an accurate value. And we got a comment here. So pressure is not the same as resistance because with poor RV function may not be able to generate enough pressure. What a great comment by her team, absolutely. So I guess we can say that pressure is a part of flow, and the part of flow is going to be related to resistance, but absolutely we're coming on to poor RV function in just a moment, and we'll be able to talk a little bit about this there. So thanks, her team. All right, what else are we interested in? So I think let's move on from what Emma was saying about the RV. I think if we got an abnormality in the parasternal long axis, we've got to go looking in other views. So for me, as you probably all heard me say a million times, the short axis view is my backup for having a look at LV and RV size and function. It's really hard to mess this view up, and it gives you a good overview of RV size. So here we're sitting at the apex of the heart, and I know it's the apex because I can't see any either the anterolateral or posteromedial papillary muscles, and we got that heavy trabeculation in that RV. But the RV doesn't look absolutely massive. I come down here and we can see with maybe, see, I'll find the best one I can. That's probably the best one that we've got. I think we've got the posteromedial and anterolateral papillary muscles in there. What do we think about the RV? Emma, I might just bounce back to you if I may, because you were doing the first one. So you said that you thought what was the beautiful term? You said generous. You said the RV was generous. What are you thinking now?
Probably corroborates that. I think it still looks generous. Possibly there's septal flattening. I need to slow it down and see whether that was in diastole or systole.
Yes, right. And how is that going to help you? What are you looking for? You're absolutely right. I'm just to explain it to the group. So this the diastole or systole, the little bounce. Oh, are you still there? Oh, she's left. Did I accidentally knock her off? Oh, I don't think so. Oh, well, I'll try and answer that question for her while she logs back in, maybe. So if you've got flattening of the interventricular septum during diastole, that suggests a volume overload process. If it's flattening during systole, it suggests diastole is volume overload and systole is pressure overload. And I just remember that because of systole, you're generating pressure. So flattening during systole is a pressure overload process. An easy way, oh, she comes back. An easy way to do it is also if you're finding it difficult to try and figure out what stage of the cardiac cycle it is, I put my cursor in the middle of the screen, and that's where I look with my eye. And then using my peripheral vision, I look at the septum. So that obviously systole is when the ventricle is coming towards the center of the heart. That's where I'm looking, and I can see therefore where the sort of septal bounce is. Does it happen during the contraction, or does it happen with the relaxation? And that's something I just find useful. But I think we can say that the RV looks to be, as Emma was saying, is generous in size. It looks almost the same size as the LV in this view. And so the next thing I'd want to go and have a look at would be my apical 4-chamber view. And here's a not super straightforward, unfortunately. I'll see if I can find you the best one we can.
Sorry, Sam, I was saved by the bell there / internet connection.
That's fantastic. It's all right. And we were just explaining to the group about the diastolic flattening being associated with volume overload of the RV and systolic flattening of the interventricular septum during pressure overload. So I'm sure you knew that. Was just explaining it to the group. So if you're back now, so here's, if we're assessing it in the parasternal long, short, we've got to back it up in other views. We've got our apical 4-chamber view. Tell me what you make of this. Because you said you thought it was generous in nature. It did look a little bit dilated in your parasternal long and parasternal short. What do you think about it in this one?
Well, it's almost, you know, apex forming. It's at least the same size, if not larger than the LV. I'd say it's at least moderately enlarged.
And
but I'd like to.
Yeah, and give me the caveat. So what's the caveat with the apical 4-chamber view? You know, the standard things I say to people who are starting doing the basic echoes, if you think that the RV is overloaded in your apical 4, your first thought's got to be is, have I messed up my image? Have I foreshortened the image? How in this view can you see if you've foreshortened it? I mean, let me ask Vishal, do you think I've foreshortened, it wasn't me taking these, but do you think we've foreshortened this image?
Like, don't think so, because, you know, can't see the corny sinus. There's a little bit corny sinus coming, but not.
Yeah, it's not the best way to see if we've foreshortened it.
So basically, you know, you need to see that your apex is not moving.
Yeah,
that's the main thing.
So if I put my little cursor there, the idea is that the base of that, this is the apex of the heart and this is the base of the heart. The heart twists, but the apex doesn't move. The apex stays in the same place and the base of the heart moves towards the apex. So if you can also put your thumb on the top of the screen and see if the apex moves, I've put the cursor there. And I think you can see the top of the heart does move a little bit down and up during the cardiac cycle, suggesting some foreshortening. That will make the RV look a little bit big, but I still think, as Emma says, this is definitely a dilated looking right ventricle. RV function, Emma, what views what do you want to have a look for the RV function? We lost her again. How about we've got,
Hi there.
Oh, hi, Emma.
Hi, sorry.
Sorry.
I guess it can be divided into like eyeballing it, and then also looking at measures of global systolic function, so fractional area change, and
Beautiful.
I guess you could do more than 35.
Beautiful. TAPSE
more than 16, and then RVS prime of more than 9.5.
Fantastic. So all of these markers, and fractional area change was about 40% or something here. So all of these markers suggesting normal RV function. So I guess in summary, what would you say with this guy with his terrible looking chest X-ray? I'll see if I, oh no, I've lost it again. With his terrible looking chest X-ray, and that was his echo. What would be your overall conclusion, please, Emma?
Well, my overall conclusion would be, you know, it's a chap with undifferentiated interstitial lung disease of some form, with probably at least moderate pulmonary hypertension, with, you know, probably moderate TR, and I would say that he's got right ventricular hypertrophy, but right ventricular enlargement, but preserved systolic function, which suggests that he's got compensation and probably preserved like RV-PA coupling. But I think, you know, perhaps working him up more, perhaps a right heart cath would be in his interest.
Very nice. So this guy's starting to become more and more hypoxic, and he ends up getting intubated. If you've looked at that previous echo, obviously we're going to show you the next echo that we've done. I feel like I'm putting words into, asking you to put words in your mouth. I think that a guy who's got moderate pulmonary hypertension, a bad-looking chest X-ray, signs of chronic volume overload, who then gets sick with an echo, with a chest X-ray that now looks like this, I think we got to make sure that we're worried about the right ventricle. I think someone who's got signs of chronic pulmonary hypertension with an RV that's dilated has got some form of adaptation going on, which puts him at an at-risk RV. And obviously some of these guys get through critical illness with no problem, but some of them don't. And unfortunately, this is one of them who doesn't. And I guess it's just important, I think, from the clinical point of view, to have people that have in my mind that that's an RV that's at risk. And so if they do get intubated, they do have worsening pulmonary infiltrates. And this guy has progressed to having the sort of interstitial pattern that looks worse. It's 4 quadrants. He gets tubed. He's got terrible compliance. I'm labeling him as ARDS. It's really important to go and look at his heart because he's got this at-risk RV. So,
Sam, can I just say something? I mean, is it ARDS though?
yeah, good call.
He's got pulmonary fibrosis. I mean, I don't know what sort of investigations and treatments he'd had in the preceding year since his CT that made that diagnosis. But at the age of 74, I would be thinking very carefully about ventilating him in the first place.
Yeah, it's a really
depending on the clinical scenario, obviously, and the patient's values and wishes.
If I could tell you that the X-ray had looked acutely worse, there was worrying about an ongoing fluid pneumonitis or infective process going on that made the chest X-ray look worse.
Yeah, then that would be a good reason to provide supportive management while treating potential reversible causes, obviously. Yeah.
It is unfortunate. I mean, I guess we could, that's why I was umming and ahhing about calling it ARDS. It helps my talk because the talk's meant to be on ARDS that I'm going to label it as ARDS. But
let's call it that then.
You don't want to spoil a good story with the truth. But absolutely, I hear what you're saying. I think we throw around that diagnosis far too easily sometimes, but it fits in really nicely with what I want to talk about today. So I'm just going to add it in. So a guy who's who's difficult to ventilate. I'm guessing use this as an example in all seriousness of someone who's difficult to ventilate in a person who's got an at-risk right ventricle, and if sorry. So this guy got intubated, and he was requiring a little bit of noradrenaline to support him, somewhere in the single figure dimensions of single figure infusions of noradrenaline to support him. And this was his echo day before yesterday that we did when he less than 24 hours after he got intubated. Who would like to have a go at this? Who have we got online? Shall we try? Ravi, would you like to have a look? Were you here? Did you see the first images? Would you like to have a look at this? Go at this one.
I'm sorry, I'm driving. I'm just listening. Sorry.
No problem. No problem. If you missed the beginning, how about we try someone else? Who else have we got? Arnie's only just joined us. Hatim, you know this guy, so maybe it's a bit unfair to ask you. Lewis, are you good to go? Do you want to Lewis McLean?
Yep. How do we document that?
Yep, can you hear me?
Yeah, absolutely. So Lewis, there's this guy with ARDS, as we're calling it. He's just got intubated. What do you think here? Oh.
A project sort of simultaneously.
Your background say optimal PEEP study.
Development. The other one is where there's
Go. Tell us,
It's left over from our other Zoom session.
Oh, that's perfect.
Sorry, just give me 2 seconds. So looking at the parasternal long, the RV size is now considerably increased. That would be the most striking finding, making me worried about acute cor pulmonale in the context of mechanical ventilation with somebody who's at risk.
So that's a really interesting comment. So let's just, first of all, you say you're calling this acute cor pulmonale. Okay, so let's just work through. So now what do you think about the short axis?
Yeah, so cardiac timing wise, so it looks like a pressure volume overloaded RV now, I think. I'd normally slow that down and just look at it, but it looks like it's essentially a D-shaped septum throughout the cardiac cycle.
Very nice.
The size is obviously dramatically increased.
Yeah, so it's now absolutely severely elevated.
Yeah.
So we did our tricuspid regurg at about 3 on the last one. What do you think of this? It's still the same. He's still got moderate pulmonary hypertension?
I think that Hatim's comment was very prescient, and that what's probably represented is the failing RV and the inability to generate higher pressures.
Perfect.
And just looking at that waveform, it looks less parabolic and a little bit more triangular. So I'd be worrying about increasing severity of TR.
Fantastic. So I also then, if we're thinking all of those, let's also have a look at his RVOT trace. So let's compare this to the last one.
So this is the mid-systolic notching that Danielle was talking about, the flying W sign.
Very nice. So,
And that would be consistent with pulmonary artery or pulmonary vascular resistance. So pulmonary artery pressure that's increased
very nice. So,
since the previous.
so just to summarize what you said, you're obviously, even though it looks like we've got the same systolic pulmonary artery pressure, we don't, because the RV is clearly obviously not working very well. We've now got this marked systolic notching, which goes along with the idea that we've got markedly elevated systolic pulmonary pressures. That's beautiful. What do you think about the RV function?
Sorry, Sam, before that, can I ask what's the pulmonary exhalation time? Because it looks like a 60-60 sign to me.
Yeah, nice. So here we've got,
It's less than 60.
okay, interesting. So 60-60 sign was a question here. So what's 60-60 associated with?
So 60-60 can be associated with acute cor pulmonale.
Yeah.
And so your pulmonary systolic artery pressure would be less than 60 with pulmonary exhalation time less than 60.
Yeah.
Because, the tricuspid valve doesn't get time to, elevate the pressure. So it can be present during the pulmonary embolism causing acute cor
Yeah,
pulmonale.
absolutely. And I think it's often in patients that haven't seen previous pulmonary hypertension before though. Because I think
that cohort was a
sorry, Karen.
Sorry. No, I was just going to say that's in patients without pre-existing pulmonary hypertension.
Yeah, nice. So I think the 60-60 sign probably doesn't apply to this guy for that reason, because he's had previous pulmonary hypertension. And now with this marked change in his RV function, and we ended up actually doing a PE study on this guy and he didn't have any PE. So I think this was all done because of the intubation and hypoxia and hypercarbia and reflex pulmonary vasoconstriction. What about RV function? So I'll just quickly show you, we've got TAPSE now is 13. We've got RV S prime that is greater than 8. And we've got a fractional area change of 25%.
So the longitudinal function has decreased somewhat, but the radial contraction looks like it's significantly reduced. It looks like there's a McConnell sign.
Yeah, I'm just going to try and show you.
Great, isn't it? Just that tiny little apical segment
Yeah.
of the RV
Yeah.
there is the only bit that's coming in.
And I'd be interested to see what the RV strain looked like.
Yeah, I haven't done that, I'm afraid. I'm just going to see if I can show you both next door to each other. Let's do that one, and let's do that one. Beautiful. So here you go. The one on the left is from the 5th. That's the one from 2 weeks ago. This one was the one from a couple of days ago. And you can just see, as Lewis was explaining, that change in that radial function. It's just the apex of the heart is trying its hardest to try and help things out. As I say, he did not have any PE, this guy. And it's just this. I think it's the whole of the RV now is not working with this marked dilation. Very nice.
Yeah.
What's amazing? Sorry.
Oh no, I didn't mention the relative size. It looks like the RV would be severely dilated now, and it is moving towards apex forming, assuming that's on axis. Yeah,
and it takes over most of the RV. If we want to look at the IVC, and the hepatic veins can really help with trying to estimate what systolic pulmonary artery pressures are, and this one's markedly dilated, didn't change with respiration, and we had some reversal of the hepatic vein flow. You can't really see it on the color here. And so all in all, just goes this exact example, I think, of someone whose RV is at risk, that then we intubate, who then the RV can dilate and become abnormal. So let's bring back to your what you were saying before about cor pulmonale. So tell me how you diagnose cor pulmonale.
There's a couple of different ways you can diagnose acute cor pulmonale. The way that I'm most familiar with in the literature is looking at the relative RV dimensions.
Yeah.
And looking at the relative size compared to the left ventricle, and ratioing it.
So big RV and poor RV function. Yeah. Anyone else?
So,
oh, sorry, are you finished?
I was going to say 0.6, ratio of 0.6
All right.
or
Anyone
more
else?
is what I think.
Got another one. There's, and Lewis is absolutely right. So I think, and the echo parameters of RV dilation and dysfunction are in there. Is there anything else? Because I think it's almost like a physiological diagnosis as well as an echo diagnosis. Because I think you've got to have all those features you described on echo, but also signs of the RV failing. So an RV failing is where the RV can no longer generate forward flow. So that you've got signs of systemic congestion is the big thing for me. So this is the contentious bit for me, because I'm, you know, there are papers that say that the idea of systemic congestion is simply having a big dilated IVC. I would argue that it's more than that. You want to see acute kidney injury, some metabolic acidosis, some lactemia, some LFT derangement, something suggestive of systemic congestion from a physiological state. I think it's more than just a dilation of the IVC, which can happen just with tricuspid regurg and good pulmonary hypertension. And what's fascinating about this guy, so in this change in the echo, his biochemistry has not changed at all. He has remained with normal kidney function, no LFT derangements. Lactate's always been rock steady at 1. There's been no peripheral signs. He managed to keep his preload quite low. And I think it's really elegant representation of how the heart can adapt, and how this is a physiological response to increased the pressure that we're generating in his chest. This is how the RV has coped with that, and his heart has done a beautiful job on keeping his cardiac output normal. This guy is on no support whatsoever, generating a MAP of 68, and he's able to do that because the RV has dilated, even with its poor function. It's hanging on by its fingernails, I think, but still able to generate enough throughput for him to have an LVOT VTI of something like 18, I think it was.
That's probably because his RV had been chronically conditioned though, right?
Absolutely. There's no way that you or I would be able to do that. So I can't remember where I saw the LVOT. There's no way that you or I could do what this guy is doing, I think, on the level of support he is, but his heart was able to chronically adapt to it, and hence he gets to the stage where he can do this. So absolutely, I agree with that.
How much PEEP you're giving?
What an interesting question. Let's go on to that now, because that's the other bit I want to show you. So he marked improved reduction of PEEP from 8 to 6, beautiful, as well as no major contribution from LV failure. So her team has helped look after this gentleman, and I think, yeah, this guy, the fact that his LV carried on working was absolutely instrumental to it as well. Yeah, very nice. What I want to show you next is this, and stop sharing. I'm going to share my desktop with you guys now. So this is obviously pretty controversial, and just going to show you what we were doing today on this guy. Can you guys see this okay? So this is the way that we set the PEEP, and why I think it's so beautiful. Lewis obviously got the memo that this is what we were going to be talking about, so he's got his optimal PEEP study in his background. I think that's fantastic. I have no idea if this is the way to do it. This is just the way that I'm trying to think about setting PEEP. I think probably PEEP, the PEEP number that you need probably doesn't matter too much in 95% of our patients. It must be the same in your units. It's either 5 or 8 or 10 on 95% of them. But there's a group of patients we need to think about PEEP very, very carefully. And those are people, I think, who've got asthma, who've got horrible atelectasis, and who have ARDS. And so with this guy, I tried a PEEP titration maneuver. This was not really meant to be for recruitment, but I think it did show that maybe there was some recruitment there. And what I look at with this is, as well as looking at the change in the PEEP, I look at peak pressures, compliance, plateau pressures, hemodynamics, saturations, and TAPSE. And I think we could argue about what the best value is to look at the RV. So this is something I'm working on. I don't know whether it's perfect, and I'd love your thoughts. So I put them in a volume control mode of ventilation. So I make sure I'm giving them somewhere between 4 and 6 mils per kilogram, ideal body weight for the ventilation. And I let the alarms go up a little bit higher for peak pressures. And so we've been ventilating with a PEEP of 6. That gave him a peak pressure of 36 with a plateau pressure of 33, with compliance, which was horrific at 12.7. That was giving him saturations of 90%, and he had a PaO2 of around about 65. And he had a TAPSE that was 18 when I measured it this morning. And this is a map of 67 on no support from a catecholamic point of view. I've then done this move where I just take his PEEP up by 2 at a time and seeing what it does to his hemodynamics, to his right heart, and to his pulmonary and his ventilator settings. And so we can see just by going up from 2 in his PEEP, I've put his peak pressures up to 42, compliance went down, plateau pressure jumped up by 5, MAP was okay, SAT stayed the same, TAPSE started to go down. As we jump up, that similar kind of pattern goes on and on as I go from 10 to 12. And I did not stay at 12 for very long with my peak pressures of 57, my plateau pressures of 56, and the MAP starting to go down and the saturation starting to go down. And most importantly, this was a dynamic process. The RV responds to changes very, very quickly. And here you can see the TAPSE is coming down into that moderate, getting down to the severe dysfunction phase. And I do each of these steps I'm doing for about 20 seconds, 20, 30 seconds max, and recording the data. Normally it's about 6 breaths and then I record the data. And then as I come down, what's interesting is that these numbers look a little bit better than the ones above, particularly in terms of the compliance. Like if you compare 8 to 8, maybe that's a bad example, 10 to 10, but more probably from 6 to 6, you can see for the same peak pressure, I've got a little bit lower plateau pressure. I've got improvement in compliance. The MAP looks a little bit better. Saturation's actually got much better after we did this. Oh, well, not much better. It went up to like 93 or something. And the TAPSE improved. And was maybe using this as an example that maybe there was some lung that was maybe a little bit recruitable, but obviously I wasn't going to do a standard recruitment maneuver where I normally go up to like peeps of 30 or even sometimes 40. But it told me that the optimal PEEP, which the other specialist I'm working with had just had set without doing this, was exactly the right one. So one could argue that you don't need to do this, you should just listen to your fellow. And but showing that, you know, getting plateau pressures of 30, that was the best one, was doing that with a PEEP of 6. And yeah, so I don't know what you guys think of that, but this is what I'm trying to do with these guys who I think need to have PEEP set as accurately as possible. And as I said, I don't think that's for every patient in the ICU. You've got to pick your candidates. I'd be interested in what Lewis, Lewis, you was just giving a talk on this. What do you think?
Paralysed?
Oh, excuse me. Absolutely. Yeah, he's paralysed, heavily sedated. You cannot be breathing spontaneously to do these maneuvers. Sorry, I didn't mention that at the beginning.
I mean, to be honest, I'd be quite hesitant to perform a PEEP titration in a patient with underlying fibrotic lung disease unless I was quite unhappy with the ventilation.
Yeah. And
that first line I wouldn't be completely unhappy with, to be honest.
Yeah, absolutely. This was one of the arguments the fellow said to me as well. And that's why I wasn't going high with the PEEP. He had horrible...
But the numbers did get better.
The numbers did get better. He had pretty bad atelectasis as well on one of the areas, which I guess was trying to do it. We're obviously not winning brilliantly with his oxygenation, and with the RV showing such acute changes, my argument was if we can improve his hypoxia, maybe this guy would have some form of improvement with his pulmonary, ventilation setting.
Well, I think the answer I'd probably give would be lung ultrasound would precede this and be looking for evidence of recruitable portions of lung, such as atelectatic portions.
Good comment. Danielle, were you about to say something?
I was just going to ask, how do you account for the fact that the plateau pressure rose so high out of context to the elevation in the PEEP? Like PEEP's gone up by 6 and plateau pressure's gone up by like 23. Was there clear evidence of gas trapping or dynamic hyperinflation at the time?
So I did take a photo of that. So I wouldn't do maneuvers if you've got gas trapping going on. That's another contraindication. So if you've got the tubes in the wrong place, not paralysed, any major risks of pneumothoraces, I don't do these maneuvers.
So why do you think the plateau pressure went up so
maybe
high?
The hysteresis thing. I think we're probably right up at the top portion of the, even with just going up in 2, I reckon it's like, blowing up a balloon when it gets to its maximum amount, it can't go any further. So just small changes in pressure have a massive increase in the plateau pressure. That would be my thought for that. And you can see that it just sort of exponentially goes up even by just going up with 6 on the PEEP.
I think Sam can you hear me?
Yeah.
Yeah, so this exact phenomena we demonstrated in the COVID patients that we had this paradoxical PEEP effect. For patients that have been on very high PEEPs, most of them didn't respond and had been severely hypoxic, while again doing the same maneuver, reducing the PEEP gradually and observing the compliance, lung compliance was actually, and even the oxygenation was markedly improving on lower PEEPs. And this was the underlying basis for Gattinoni when he described the COVID to be 2 subphenomena or subphenotypes. The one that actually had got good lung compliance and the ones that had got very poor lung compliance. So it's a sort of similar description that probably there is an element of pneumonitis happening. And whenever I'm doing these maneuvers, I would actually put the flow, the pressure volume loop, rather than having the standard curves. And then I would be observing, having a reference loop, and then after that, going from that, which direction is the lung compliance going with, even with the single manipulations of 2 or 3 centimeter waters of PEEP.
Fascinating. I'd love to see how you do that on a ventilator. You must show me.
Yeah.
Brilliant.
Just a quick comment that, small observation that his right heart functions, is better as compared to your echo, because TAPSE was 13 on that and it's 18. So it's just with time, or did you do anything different?
No, and I think it's probably more in keeping with the TAPSE is sometimes a little bit tricky. I'd argue that the measurements that were made were, of the previous one, I don't even remember, were maybe off axis and maybe being recorded in a less than ideal format. So I think I'd say, we could argue whether TAPSE is the best measurement to do. I think if you're doing this, I keep my hand in the same position at all times. So it's a 2-person technique that I just keep my hand there. If you're doing it by yourself, you've got to make sure you've got the ventilator within easy reach. So I use my sort of top 3 fingers to keep, I find a view and I just stick with that. And then I change the ventilator. And if you're doing it, change the ventilator and you've got your sheet of paper and write it in front of you. But your hand always stays in the same position to try and make sure you're comparing eggs with eggs. Yeah. So maybe, I think this would be a really interesting study on patients like this. I'd love to get 10 or 15 of us, one after the other, going along and doing measurements of RV function. I bet our TAPSEs would all be different, which is why it's so important to try and have multiple measurements and try and put them all together. But I don't know.
Yeah, I think again, this returns back to the physiology underlying. So whenever you are applying higher PEEP, there will be increased resistance across the pulmonary artery.
Yeah.
And this definitely would compromise the RV function. Yeah. So no wonder in this patient that they may not cope with this amount of increase in pressures.
Yeah. All right, guys. I hope that was useful. I found this case really fascinating. I really thank the patient and his family for letting me discuss this. If there are no other comments, I might sign off there and say thanks very much.
Thanks, Sam. Thank you.
Thanks, guys.
Thank you.
Thank you.